Well, thank you very much for the introduction. I would like to thank the organizing committee and in particular Dr. Christine Erlandson for the opportunity to speak with you here today. This is actually my first time at this conference and I'm very excited to participate and to learn from all of you. And as you can see by the title of this talk, we have a bit of ground to cover today. So what I would like to do in the next 18 to 20 minutes or so is to talk to you about some of the changes that aging exerts on the pharmacokinetics and adherence of antiretroviral therapy. And I would like to focus a little bit on some of the methods that are currently available to quantify adherence and how do they relate to older patients living with HIV. I think we're also going to review today some of the antiretroviral therapy along the aging continuum. And I will try to discuss with you some of my thoughts on the possibility of dose modification for older adults in the age of modern therapy. I will also touch a bit on the new formulations that are becoming available to treat HIV, in particular long-acting injectables. And I will finalize my talk with what I think are the main knowledge gaps in the field and provide you with some ideas on what the research agenda is going to look like, I think, in the next decade as we move forward. So I think everybody in this audience is well versed on the changes that are driven by human physiology during aging. And I think several of them are very influential to pharmacokinetics, not just of antiretrovirals, but all of drugs in general. For example, we know that older adults have lower free water to and a higher adipose tissue and decreasing their free water to fat ratio. And that increases there are also decreases in lean body mass. This has a significant impact on the volume of distributions, such that drugs that are polar have a smaller volume of distribution and a shorter half-life in comparison to drugs that are not polar and are fat-soluble that usually have a larger volume of distribution and a longer half-life. Drug absorption and plasma proteins are also decreased in aging, and that impacts the amount of free drug available in plasma in some older adults, and that may impact some of the efficacy of the drug. And renal excretion and hepatic blood flow are also decrease during aging with a concern of potential decreased hepatic metabolism of some medications. So all these changes together can result in variable pharmacokinetics, which may impact drug efficacy and may narrow the therapeutic index of a drug and lead to more toxicity. Now, along with the physiologic changes that are present in aging, there are also some pathologic changes that can influence drug pharmacokinetics. For example, with aging comes the accumulation of comorbidities. And these comorbidities can impact pharmacokinetics not only due to an accentuation of the physiological changes that I already mentioned, but also to the addition of new drugs to treat them that can alter drug absorption, metabolism, distribution, etc. Similarly, with aging comes high inflammation. And we know that inflammation actually affects the expression of some transporters and some proteins that are metabolizing proteins, for example, like the cytochrome system, that can lead to a slower metabolism of some drugs. Also, cell senescence that is seen with aging can impact pharmacokinetics, particularly of those drugs that undergo intracellular metabolism, like some of the antiretrovirals we use currently in clinical practice. So what do we know actually about the pharmacokinetics of antiretrovirals in older adults? Well, in reality, we don't know much because there really have been only very few studies that have been controlled to evaluate pharmacokinetics in this population. For example, data from studies in nucleoside analogs initially demonstrated no differences in the pharmacokinetics of abacavir, for example, while studies that looked at lamivudine and tenofovir actually found that the age correlated with drug concentrations and clearance of these drugs. Regarding other classes like non-nucleoside analogs or protease inhibitors, I think the general consensus has been that age has not really been a big influence on drug concentrations of these classes. And this also seems to apply to integrase inhibitors, although data are less limited. And there was actually a recent study that observed increased exposure to dolutegravir in older adults, but really without any clinical consequence to note. The problem that I personally see with all the studies looking at pharmacokinetics in older adults is that they have actually focused on plasma drug concentrations as the primary outcome to evaluate. And I think while this makes sense, I think most of the studies have overlooked the opportunity to look at drug concentrations at the site of action. Although this has been recently looked at, for example, several years ago, a study looking at nucleoside analogs and their phosphorylated metabolites intracellularly identified no differences in the concentration of phosphorylated lamivudine or cidobudine in older adults. However, a couple recent studies actually found higher concentrations of tenofovir diphosphate and M-tricytidine triphosphate in peripheral blood mononuclear cells in adults who were 60 years and older. This was also similar to a study that identified high concentrations of tenofovir in hair and tenofovir diphosphate driver spots in the same population. What is interesting in these two couple of recent studies is that these findings became less significant after the studies controlled for covariates, which I think raises the point that it's not chronological age per se, but it's the factors associated with aging that are the ones that likely drive these differences. Now, similar to the influence of pharmacokinetics in aging, aging can also exert significant impact on adherence and behavior, which is what I'm showing here. For example, as people get older, they accumulate comorbidities and they increase their pill burden. And if they have had a chronic illness for many years, they eventually may get tired of taking medications because either they don't want to take them anymore or they don't think they are necessary anymore. Unfortunately, older adults are also prone to social isolation and loss of emotional support, and alcohol intake may also increase as people get older. You can imagine that these behavioral changes can be accentuated and exacerbated by the presence of mental health comorbidities, like, for example, depression or anxiety, which are highly prevalent in older adults, and also, of course, by cognitive decline. So collectively, these factors can contribute to low adherence, whether it's intended or unintended, and influence drug efficacy. And similar to the data we have in pharmacokinetics, the data that we have on adherence to antiretroviral therapy in older adults is also limited and conflicting. If we look at for example, if we look at drug adherence to antihypertensives in the general population, for example, we see that older adults, particularly of minority backgrounds, have lower adherence to antihypertensives with an impact on blood pressure control. But when we look at blood pressure, at antiretroviral therapy adherence in particular, we actually see the opposite, and we find that older adults in a study had a higher adherence compared to their younger counterparts in the ratio of about 20 to 30% higher. However, despite these, the rate of viral control and viral suppression in older adults of greater than 55 years old is still only 60% according to data from the CDC. So I think the true level of adherence in this population is not yet fully characterized. And if we were to take a closer look at the factors that drive adherence in older adults, I already mentioned pill burden at the beginning, earlier in the talk, and I think it's a well-known fact to many of you that polypharmacy, which we usually define as taking 5 or more medications, can actually translate into lower adherence to antiretroviral therapy and many other medications. Other factors like female gender or residing in a rural community have been associated with low adherence, while other factors like high income and high self-efficacy have been associated with high adherence. And as you can see, obviously adherence is a very complex concept, and the complexity associated with it in the general population accentuate as people age. I do want to say a word about polypharmacy, which of course has an impact on antiretroviral adherence, as I mentioned. As you can see here from this study in Spain, where polypharmacy was associated with the lower odds of achieving high antiretroviral adherence of 90% or more in our population in Spain, and with the impact that it has in viral suppression. And polypharmacy is not only associated with adherence, but it also has been associated with high incidence of drug interactions and with functional decline. But I think it's not just the number of medications what matters, but it's actually how complex a regimen is. And regimen complexity is actually dictated by factors such as, for example, how many times a day a medication is taken, whether it's an oral route versus an injection, whether it's supposed to be taken with food or on an empty stomach. And the medication complexity can actually be quantified numerically using a standardized tool. At least in HIV, seems to be primarily driven by non-antiretroviral medications, as you can see here in this study from Colorado. Just to orient you, in the y-axis here, we have the complexity score that can go from 0 to infinity, for example. And you can see that the contribution of antiretroviral therapy in black is not very high compared to the contribution of non-ART medications in light gray, and the contributions of over-the-counters in dark gray. And recently, high medication complexity has been associated with lower antiretroviral adherence and lower cumulative drug exposure in persons with HIV. Now, I've already told you that quantifying adherence is important, so I guess your next question is going to be, well, can we really accurately measure? And well, to achieve this, we have a wide range of adherence measures, as you can see here in the slide, that go from, for example, self-report as the most objective one in the left of the slide, all the way to direct observed therapy as the most objective in the far right. And as you can imagine, every single one of these measures has limitations that we can talk about. And even direct observed therapy, for example, has its hurdles. I do want to emphasize that HIV viral load in this spectrum sits pretty much in the middle, and that a suppressed viral load doesn't necessarily mean high adherence, and particularly now in the era of modern art and potent art. As you can imagine, quantifying adherence in older adults comes with its own challenges. For example, self-report, which we use regularly in clinical care, is very prone to be affected by recall bias, which can be accentuated in some of our older patients who have cognitive decline, for example, or memory problems. If we get into more sophisticated methods, for example, like electronic monitoring, we will definitely run into barriers with implementation and learning of technology. And there was actually a study that found that poor attention span and poor executive function were associated with inability to correctly use electronic adherence monitors. An exciting new field is the field of digital pills, which basically are ingestible biosensors that are combined with medications to objectively quantify drug ingestion and input. When the sensor that is attached to the pill reacts with the gastric fluid, it generates a small electrical signal that is transmitted into a relay system that is usually outside of the body, like in a lanyard or a patch. And that signal can be transmitted then to the cloud. One of the advantages is that these readers can also quantify physical function, vital signs, etc., which are also interesting and could be helpful in older patients. Obviously, digital pills are early on development, have these advantages that will need to be addressed before they can be implemented. One of them is going to be learning the technology in some of our older patients, but also cost and concerns about implementation and privacy are going to have to be addressed. If we move now into pharmacologic measures of adherence, I think the key here is to understand that the information that these pharmacologic measures are going to give us is directly dependent to the half-life of the molecule that we are measuring and in which matrix we are measuring. So for example, if you look at the top of the figure here above the dotted line, you can see that plasma, urine, tenofovir concentrations, and tricytidine triphosphate in dry blood spots are measures of short-term adherence and recent dosing. And this is due because their half-life in those matrices runs very short, in the order of hours to days. In comparison, if you look at the lower half of the slide below the dotted line, you can see tenofovir diphosphate in dry blood spots, and drug concentrations in hair are measures of cumulative adherence, which is due to their long half-life in these matrices that runs in the order of days to weeks. So if you were to think about it in terms that are very familiar to all of us, like diabetes, for example, your upper half of the slide will constitute your glucose measurement, while the lower half of the slide will constitute hemoglobin A1C. Measures of cumulative adherence, like drug concentrations in hair and in dry blood spots, have actually been associated with viral suppression and are actually predictive of future viremia. But the limitation is that they actually have only been evaluated in one study comparing older versus young adults. And this study found no differences in drug concentrations in these matrices in adults older than 60 years old compared to younger persons with HIV who were virologically suppressed. The limitation that these measures will have is that, for example, hair may not be always available in older adults, and there's also an influence of hematocrit on drug concentrations of dry blood spots, which hematocrit tends to decrease with age. So if we accept the premise that drug exposure, that aging is going to actually lead to high drug exposure, we could propose that aging actually influences two critical outcomes in HIV care. One is viral suppression, and that is basically related to drug forgiveness. Forgiveness being defined as the ability of an antiretroviral to maintain viral suppression when adherence is less than 100%. Now we know from recent studies that patients do not have to be 100% adherent to be suppressed, and that actually 80 to 85% adherence may be enough to maintain suppression, which is a great advantage of the new drugs. But what the problem is that incomplete adherence is actually associated with higher immune activation and higher inflammation and coagulopathy, even in persons who are virologically suppressed. And these actual consequences have been associated with mortality in persons with HIV. And we also do not know if incomplete adherence in a very forgiving regimen over time can actually lead to the development of drug resistance in the long run. The other clinical outcome that high drug exposure would affect would be drug toxicity, which in part is mostly driven by high drug exposure over time. Well, we are all familiar with some of the adverse events and effects that many antiretrovirals have. I think we need to focus a little bit more on the consequences of high cumulative exposure over long periods of time. And we have recently learned that high exposure, as measured by tenofovir diphosphate in dry blood spots, is associated with endothelial activation and monocyte activation, and also with decreased bone mineral density in the hip and poor physical function, all of which are risk factors for falls. So a question that comes to my mind is, well, can we get away with modifying dose to reduce toxicity in older adults without compromising efficacy? And to answer this question, I think we can propose looking at aging, toxicity, and forgiveness in a graphical form. Here you can see in the upper panel that as age increases, toxicity will also increase and will eventually cross a hypothetical threshold for organ damage that is presented here in the dotted line. Comparatively, in the lower panel, you can see that forgiveness also increases as a function of age. And this could be viewed as beneficial, of course, as I mentioned earlier before, in many patients. Now, if we're going to perform a dose modification to decrease toxicity, for example, we're going to have to look at some of the specific patient characteristics that may be influential in these relationships. So, for example, if we were to choose a body mass index as an example, we could potentially see that a dose reduction in someone with a high BMI could be associated with a decrease in toxicity below the threshold of organ damage, as shown here in yellow. But if this dose reduction is coupled with a very impactful decrease in forgiveness that falls below the threshold for viral suppression, as you can see there in yellow again, I think that is obviously something we would not pursue. In the contrary, for example, if the ideal case scenario would be a dose reduction in someone with a low BMI, in which considerable reduction in toxicity is achieved below the organ damage threshold, with very minimal impact on forgiveness, as seen here in blue. And these patient-related characteristics doesn't have to limit to BMI, but could be driven by physical function, inflammation, concomitant comorbidities. And I think we're going to have to look at those more carefully in the future if we want to evaluate these potential interventions. Fortunately, now we are facing the era of antiretroviral therapy, where monthly or every 2-month injections with long-acting antiretrovirals are available. Certainly, we're going to have to face some challenges when we provide these drugs. I mentioned at the beginning of the talk that muscle mass decreases by 30% with aging. And one of the questions that comes to mind is this going to lead to erratic absorption of injectable formulations in older adults? We don't really have a lot of data on the 2 available drugs that have been used for injections, like cabotegravir and rilpivirine. We do know a little bit that rilpivirine showed similar efficacy in previous studies in adults that were 50 years or older. But what we do have is actually accumulation of experience of long-acting medications, like, for example, antipsychotics in the older population. And I think that's something that will be encouraging in the future to use this mode of delivery. You may be familiar with the Atlas and Flare studies that recently shown that long-acting cabotegravir and rilpivirine were non-inferior to oral antiretroviral therapy. But the problem with these studies is that only 30 participants in the phase 2 and phase 3 studies actually were older than 65 years old, 65 years of age. Although they didn't seem to be any difference in this population, but the data are limited. Now, for this talk, I actually looked at 4 different antiretroviral guidelines to see if they were addressing treatment in older adults, and found that only 2 of the treatment guidelines have a specific section dedicated to adults, and none of them provided specific recommendations geared towards the optimal treatment or optimal regimen for older adults, and none of them discuss dose modification in this population. So I think moving forward, there is still a lot of work that we need to do to address some of the knowledge gaps that I just mentioned. And here in this slide, I try to present what I think would be the research agenda in the next decade when we look at the intersection between aging, pharmacokinetics, and adherence. First, I think we're gonna have to identify which regimens have the most favorable pharmacokinetics and the lowest toxicity, and also perform studies of long-acting injectables specifically geared towards older adults. I think we're also gonna have to try to better understand antiretroviral forgiveness in this population and what are the best and most informative adherence measures in older adults. And we're also gonna have to understand what are the consequences of overexposure over time. And I think we have to give at least a consideration to perform clinical trials of dose reduction in adults who are 65 years old or of age or older. So in conclusion, I think the influence of adherence and pharmacokinetics, I hope I convey the message that those are very complex and not yet fully understood. But I think this knowledge gap is actually limiting the ability for us to provide the highest benefit of art of antiretroviral therapy that we can to our older patients. Quantification of adherence in this population will continue to be a challenge, and we'll need to figure out the ideal measure to quantify adherence in older patients with HIV to improve clinical outcomes overall. And I think we have a very broad agenda in terms of research ahead of us with the goal to optimize therapy by minimizing toxicity without compromising efficacy. And with this, I would like to thank you for your attention and for the opportunity to be here. I would like to thank all my friends, colleagues, mentors, and collaborators that are listed in this slide, our study funders, but most importantly, every study participant who has donated their time for the research that is presented in these slides. I appreciate, again, the invitation, and I am happy to take any of your questions. Thank you.